All of us have learnt about pneumothorax right since our undergraduate days. We know that pneumothorax is collection of air in the pleural space. Now, when we consider what are the immediately life-threatening chest injuries, pneumothorax, tension pneumothorax ranks number 1. Among others being open pneumothorax, massive hemothorax, flail chest, which Dr. Vasisht has just now discussed, and cardiac tamponade, which will be discussed subsequently. The point is, these are immediately life-threatening injuries. You must know that they can threaten life. You must actively look for these injuries. Do not wait for any investigation and immediately intervene. Because even in the best setups, at times you may not have a portable X-ray which is handy. You may not have an ultrasound which may be available. So you must know, recognize them, and without any investigation, intervene. That is very important. Simple pneumothorax, where there is slight collection of air, is usually diagnosed on X-ray. And if it is asymptomatic, nothing needs to be done beyond observation. If you are clinically good, you might be able to recognize it. You may confirm it by an X-ray. But it doesn't change patient's hemodynamics. Open pneumothorax is typically seen in a patient with penetrating chest wound which is open. So it presents to you like a sucking wound in the chest. And if it is a one-way communication, that means the opening is not very big. With every breath, when the chest wall expands, the air will go in, and as the chest wall collapses during exhalation, the air can't escape. So with every breath, it will keep increasing and ultimately lead to a tension pneumothorax. But if it is two-way communication, typically large wound where in and out movement of air, it causes pneumothorax, but it's not immediately life-threatening. Tension pneumothorax is immediately life-threatening. What happens in tension pneumothorax is because of the pressure inside the pleural space, there is shift of mediastinum to the opposite side, and it compromises venous return, and therefore there is no cardiac filling and there is no cardiac output. This kind of shock is called as obstructive shock. So typically patient presents in shock, and the knee-jerk reaction of most surgeons is that because patient is in shock, they give fluids, to which the patient doesn't respond. So it's a common mistake to attribute this hypotension to hypovolemia, which by far and large is the commonest cause of shock in trauma, and that needs to be taken into consideration. So any pneumothorax patient, any patient in hypotension, we have to think in terms of tension pneumothorax. If there is not much associated volume loss, these patients will also have prominent neck veins. So how we diagnose pneumothorax? Clinical. If you have a good emergency department, you may have a portable ultrasound, so it may come handy. Today, point of care ultrasound in ED is rapidly becoming the norm in advanced trauma care. And like you do focused assessment by sonography in trauma, you can also extend it to chest, what is called as EFAST. To diagnose pneumothorax on CT scan is not a good thing, but at times you may have to resort to it, how I will discuss subsequently. So how does a patient with pneumothorax look like? Look at this patient. He is in respiratory distress. You can appreciate these distended neck veins, accessory muscles of respiration are working, and he is tachypneic. Oxygen is being given by mask, still he is restless because he is hypoxic. Now there also there can be a pitfall. This hypoxia could be attributed to head injury, and without doing anything patient might be taken to CT. Now if you diagnose it by percussion and auscultation, all you need to do is put a large bore needle in second intercostal space in mid-clavicular line. it will immediately decompress the pneumothorax. You will hear the hissing sound. But that is not a complete treatment. It must be followed by insertion of a drain in fifth intercostal space. Apart from what we saw in this picture, you also will get tracheal shift and shift of apex impulse to the opposite side. Now, how do you do needle thoracocentesis? You can see the manubrium sterni, follow it laterally, you will get the second rib. Below that is the second intercostal space, and in the nipple line, if you put this assembly of the angiocath with the syringe, if you aspirate, normal lung you won't be able to aspirate, the piston will go back. If there is pneumothorax, the piston will not go back because there is air inside. And when you withdraw the needle, you will get hissing sound. Many times if you use plastic cannula, actually it can collapse with the pressure of the surrounding tissue. So it may be a good idea to put a large bore metallic needle. Again, must be followed by an intercostal drain. The patient with open pneumothorax, like this patient with bullet, will be a sucking wound, and to prevent its further expansion, you can put a paper and tape it from three sides. The logic being, if it is one-sided communication or two-sided communication, when you put a paper, when the patient breathes in, paper goes in, so air can't go in, and when the patient breathes out, on the fourth side which is open, the air escapes out. So again, this is to be followed by an intercostal drain insertion. After having understood how we clinically see the patient, this is how a portable X-ray may look like. You get on the right side here, you see bronchovascular markings extending to the periphery. Here you don't see any bronchovascular markings. In fact, you see a collapsed lung here, the depressed dome of diaphragm, widened intercostal spaces, shift of trachea, and shifted mediastinum. All these point towards tension pneumothorax. Actually, it reflects very badly on the managing surgeon if you take an X-ray of tension pneumothorax. That means you have actually missed to diagnose it clinically. As compared to that, closed pneumothorax, there won't be any shift of mediastinum. You do see bronchovascular markings, but here you see the lung gauge, and beyond that there is all hyperlucency. Okay, that is indicative of pneumothorax. The problem is, closed pneumothorax, you may not treat it, but it needs close observation. So if you can ensure that you are able to monitor this patient, you perhaps may just observe the patient. But all tension pneumothoraces in the initial phases will be closed pneumothoraces. So there is all possibility that this may get converted into tension pneumothorax in next 1 or 2 hours. So if you are not in a position to monitor the patient, better put in a chest tube. Apart from that, there are certain indications to which we will come to later. Sometimes massive chest trauma, bilateral chest injury, it may actually look like emphysematous chest with teardrop heart, but there is no bronchovascular markings on either side, and this patient must be extremely hypotensive and in distress. So he needs bilateral ICD. Hemopneumothorax, there won't be any diaphragm seen, and cardiophrenic costophrenic angles will be obliterated apart from collapsed lung and hyperlucency. Today, if you have an ultrasound, you can do E-fast. You see this typical comet tail sign which is normal, which is absent in case of pneumothorax. And if you go to M mode, this seashore sign is the normal picture which you get, like a seashore, waves coming and going. But they get fixed because the lung is collapsed, and you see something like a barcode sign or a stratosphere sign in case of pneumothorax. What is the role of CT? I will never advocate CT to diagnose this, but we have one patient, he was a massively obese patient where we could not subject him to, we could not clinically diagnose. We subjected him to whole body CT scan, and between his initial plates and late plates, we could see a small pneumothorax expanding. On this basis, we preemptively put an ICD, considering that he could have later developed tension pneumothorax. So such selected cases you can make use of CT. When do you put chest tube? All patients in distress, you need to put chest tube. So all tension pneumothoraces, open pneumothorax which you put three-sided seal, or all simple pneumothorax patients who are in distress, or a patient who is having comorbidity. Patient is already a COPD patient, you need to put a chest tube. More than 30% simple pneumothorax, better to put in a chest tube, or the one which is enlarging as we saw in that CT. Bilateral injury, multisystem injury. Any patient of pneumothorax, even if it is simple pneumothorax, a stable patient who is being transported out of the hospital or to a CT scan or to OR, chest tube must be put in. Particularly when you are subjecting to emergency surgery, say multiple fracture ribs, he is undergoing surgery for hemoperitoneum. He is not going to be available for monitoring, so better put in a chest tube. Any patient who is going to be intubated and ventilated, flail chest patient who is going to be intubated and ventilated, if there is lung tear, may develop subsequently into a pneumothorax and a chest tube may be necessary. Patients with subcutaneous emphysema will also need a chest tube if there is associated pneumothorax. Let us see how to put in a chest tube. We generally put it in fifth intercostal space in mid-axillary line, but in an obese patient where it is not possible to count the ribs, you can just take patient's own hand, put it in the axilla, and wherever is the lowermost level, that is the site you choose. You give local anesthesia. You must be along the upper border of the lower rib, because along the lower border runs the neurovascular bundle and you want to avoid injury to that particular site. You take an incision, go deep, but the muscles will have to be cut, because particularly in a young patient who is muscular, you may not be able to penetrate it through the artery forceps. Remember, don't take a normal medium-sized artery forceps. You need Cockers or Roberts, big artery forceps which are strong, in order to enter in the pleural space. Now when you enter the pleural space, as you can see in this video, you get a give way, and once you have got the give way, you enter inside. Here probably there is resistance, so incision is being taken to cut the muscles. And then once you enter inside, you widen that opening. And once you widen that opening, you put your finger inside. This is called as digital thoracotomy or digital exploration of the chest. See, here you get give way, and then you widen the tract and put your finger inside. What do you look for? There might be adhesions, there might be a clot sitting, so you can create some space. On the left side, you must look for tense pericardium, look for diaphragmatic injury and herniation, and palpable abdominal organs which have herniated through. This also widens the tract so that you can put the tube comfortably inside. And you fix the tube in place and connect it to the underwater seal. Here you can, once you connect, you see the bubbling. This is a very important procedure which all general surgeons must know, because it is a life-saving procedure. And underwater seal must be kept ready, and you see the bubbling. Post-operatively, you must have chest physiotherapy, analgesia, appropriate fluid management, tetanus prophylaxis and antibiotics. Post-ICD X-ray, if it shows collapsed lung with the ICD in place with continuous bubbling, that is the time to suspect major bronchial injury, and this patient is going to need consultation with a thoracic surgeon. Today it can be diagnosed by virtual endoscopy or bronchoscopy with CT scan or fiber optic bronchoscopy, and then this patient goes to a thoracic surgeon, or if you are competent yourself, you can go ahead with the intervention. Iatrogenic pneumothorax, once you intubate the patient and ventilate the patient, the tear may leak, and get converted into a tension pneumothorax. So prophylactic intercostal drain is necessary in such patients. So the take home message is tension pneumothorax is a life-threatening emergency. It needs expeditious drainage on clinical suspicion, prophylactic drainage of simple pneumothorax if it cannot be adequately monitored. Consider bronchoscopy in case of persistent air leak and failure of lung to expand on ICD insertion. And tracheobronchial injury often needs surgical repair. Post-operative care, particularly physiotherapy, is extremely important. Thank you very much. I thank the organizers for giving me this opportunity.